Good evening, everyone. Welcome from Channel 19. I'm Dr. Shawkat from London studio. So today's program on Health Plus is a special show from Health Plus is doctor safety and COVID-19 virus. I think probably one of the very known name across the world is COVID-19 coronavirus. The reason is that already so many lives has taken by COVID-19 coronavirus. And especially in United Kingdom, in the United States, and lots of European countries, China, lots of people died because of COVID-19 coronavirus. And in Bangladesh, is already around 2,000 people died because of COVID-19 coronavirus. What is different from many other countries in the world, in Bangladesh, and around 70 doctors, more than 70 doctors died because of COVID-19 coronavirus. And we don't know the reason why that many doctors died because of COVID-19 coronavirus. Not only died, lots of doctors are also infected with COVID-19 coronavirus. And I'm running out my tissue paper every day, wiping my eyes. I cry secretly. I can't tell people how saddened I am by hearing every day the news of doctors are dying in Bangladesh. Yesterday, 5 doctors in Bangladesh died because of COVID-19 coronavirus. But I cannot sit alone. My thought is always going on. What can I do? What can I offer? And what kind of initiative I can take that might help Bangladeshi doctors, not only doctors, other healthcare professionals, that might help Bangladeshi policymakers make some decision. Is there anything we are missing? If we start that practice from tomorrow, that might save doctors' life, that might protect other healthcare workers' life. So for that reason, doctor safety and COVID-19 coronavirus, this is the special show from Channel 19. Those who cannot watch this program live, what I would request you to, we have got YouTube channel of Channel 19. You go to YouTube channel and you can watch our every show after we finish our live show. So I have got panel members, 2 doctors from Bangladesh and 2 from Britain. The reason I have recruiting my panel from both this country, I trust this show will bring both Bangladeshi doctors closer to the British doctors. Both countries' doctors will try to and try to understand and feel what is lacking, how they are facing these challenges while they are at work. And also, this program, I trust, will bring these 2 countries more closer during this challenging time. And I'm introducing our panel, and you can see Dr. Silk Nia. So can you say hello to our viewers, Silk?
Good afternoon to everybody.
Thank you, Silk. Silk is a consultant cardiologist at the Chelsea Westminster Hospital, and he's a clinical senior lecturer at the Imperial College London. This is not only something I can tell about Silk. I do not want to say many things about Silk's experience and engagement in the professional world. And Silk is a current president of Royal Society of Medicine Cardiology section. It's a very prestigious for any clinician's life in the United Kingdom. And when I have invited Silk, I was actually surprised when Silk invited this invitation. And thank you, Silk, very much for joining this show. And in addition to that, Silk is a Commission Secretary for British Cardiovascular Society. And I hope, and through this show, doctors and patients in Bangladesh will know there is another doctor from Britain who feels Bangladeshi patients, who feels Bangladeshi doctors. Now I'm introducing Resham Barua. Resham, I think probably in cardiology field, and lots of cardiologists knows Resham because Resham visited Bangladesh back in 2018, and when there was a first ever conference in heart failure, and actually Resham of center of attention for the heart failure conference because she is a consultant cardiologist, a hospital, Sukuar Hospital, Hospital, and also clinical senior lecturer at the Imperial College London, and her all passion for treating heart failure patients. She did her PhD in the heart failure, some uh, checking some exercise testing. I think probably Resham will tell more about that. And in addition to Resham has got another hat. She is actually helping and shaping British guidelines for heart failure management in NICE, that's the national guideline. So Resham, in addition to that, she studied London School of Economics, and I think probably her experience from that area that will help any developing countries how to they can actually balance their budget and provide the best care to the patient in Bangladesh. Thank you, Resham. And Resham is a very, very good friend of Bangladesh. And I'm very proud. She's a very good friend of mine. We actually exploring lots of things together. And actually, doctors' safety and COVID-19 virus, she has engineered this program. And thank you, Resham, for joining us again with the Bangladeshi program. I know how busy
Thank you,
you are,
Monjo.
and now I'm introducing my very good friend, my childhood friend, and Dr. Hasina Nasrin. She was the first ever infectious disease control specialist in Bangladesh. And we have got like when we are like in secondary school, like we have got lots of like study together, lots of race, lots of competition, who can do better result in exam. But in professional area, she is such a genuine specialist in that very area of infectious disease, and like she has helped so many doctors in Bangladesh, lots of like publication in international journals. On the top of that, she has a big hat. She is actually the registrar of the management hat. She's actually registrar for Chittagong Medical University. So like that's why she has got lots of followers, lots of doctors from Bangladesh are watching her program. What she is telling during this show today, and how actually what will be her suggestion to protect doctors in Bangladesh. So Nasrin, you have got a lot of responsibility to tell the Bangladeshi doctors and viewers and policymakers. And my other guest, I'm actually a big fan of Dr. Lutfi Rahman, a very good friend of mine, a legend cardiac surgeon in Bangladesh. And I think government should look after him because he does 1,000 operations every year. And otherwise, this patient should can go to our neighbor countries. So how much money he is actually paying back to government revenue, and that's how he is making life people's life so comfortable, so easier. And he is, I think, if you ask anybody in Bangladesh, maybe in the Dhaka airport, if you ask anyone, do you know Dr. Lutfi Rahman, a cardiac surgeon in Bangladesh? You'll find few people say, yeah, we know where he's working. Currently, he is head of cardiac service surgery division at Lab 8 Hospital. That is the best cardiac hospital in private sector in Bangladesh. And Lutfi is so popular among patients, doctors, policymakers, and you'll glad to know that he has got around 1 million followers, those people following him, what he is doing. I think lots of his followers are now watching, and that's what he's talking about to protect Bangladeshi doctors. I think this is the brief introduction from me and all these panel members, those who have joined with us. So now we get back to our main discussion to the reason we are here today. I'm starting with Suk. So can you tell me briefly about a safe environment for doctors at the workplace during COVID-19 era?
Thank you, Monjo, for that question. So COVID-19 is clearly a very highly infectious and quite dangerous virus, and is readily spread to doctors and other healthcare workers because of the viral load they'll be exposed to. The closer you are to patients, the prolonged exposure you will have, the greater the chance you have of acquiring the virus. And clearly, healthcare workers must be protected because they are a valuable and essential resource that if we become unwell, then we are unable to care for more patients. So it's absolutely essential that healthcare workers are protected. Here in the UK, we went through a significant period of where the nation was in a period of lockdown or quarantine, which led to a drastic reduction in the number of patients attending hospital. And almost all those people attending had either COVID-19 or a complication of COVID-19. And we went through a process of protecting staff, and we have learnt over the last few months the best ways of doing this. I think the best way will be to screen patients at the entry point for the hospitals, and that is to look for clear markers and signs of infection. And obviously the most common and easily detectable signs can be a temperature. A high temperature of more than 38 centigrade is likely to represent that the individual has a viral infection. There are other parameters. We can ask patients about whether they have a cough, lack of smell or nausea, and whether they are breathless. But there are other symptoms that patients can have, including chest discomfort or chest pain, and also gastrointestinal upset. Now, once you've identified patients as being potential carriers of the virus, it's important for them to be moved into zones within the hospital in which they are kept away from patients without the virus, and for the staff to only approach and care for those patients with the appropriate protection. And by protection, I mean what is referred to as PPE or prophylaxis equipment to prevent picking up the virus. Here in the United Kingdom, I think we were slow to get the right equipment, but it is clear now that physicians and healthcare workers need face masks to protect them from getting the mucosal spread, goggles, ideally to protect the eyes and the mucosa, and ideally, if available, a full face shield in order to prevent patients from coughing onto you. Physicians or healthcare workers should be in blue scrubs like I'm wearing now in order for them to be readily cleaned and disposed of every day to prevent people from taking the virus home with them and spreading to vulnerable relatives at their own place. And then with unwell patients who need to have advanced therapies with oxygen delivered through airway pressure devices like CPAP or intubation, it's very important that they are cared and nursed for in dedicated units, because equipment like CPAP is what we call aerosol generating. It creates a very fine mist that spreads around the entire room, and therefore all healthcare workers in that environment will be at high risk of picking up the virus. It's a good idea for healthcare workers in that situation to wear personal respirators, which are now increasingly available. And these are a little bit like people wear during scuba diving, so full face protection with an air system that is run through a filter. And these technologies are rapidly becoming available. They are very cheap and they're easy to manufacture because they are essentially not much different from standard equipment that is worn by professionals in the development industry for house building or in underwater diving. So these are key steps that were taken in our hospitals to be able to protect both patients as well as healthcare workers.
Mondor appears to have frozen. Suk, what was the most effective thing, do you think, that you utilised at Imperial?
So I work, as you know, Resham, a number of different hospital sites across London, including the Hammersmith Hospital, which is as part of Imperial, as well as Chelsea and Westminster. And the different hospitals moved eventually in the same direction. the equipment that was given to staff that was most effective was the introduction of FFP2 and FFP3 face masks and the introduction of visors. I think once these became readily available and staff were wearing these, I think the infection rate amongst doctors went down significantly. In the United Kingdom, it was very telling that many of the physicians that passed away from COVID-19 did so having had been either in general practice or were ENT surgeons or emergency physicians. And so they were seeing patients up front without having the appropriate protection, and therefore got very high. They developed very severe symptoms from the virus. By protecting physicians, particularly like those available in intensive care or in the cardiac catheter lab where I principally work, we found that the infection rate amongst those doctors was much lower because they were used to wearing the appropriate protection.
And can you tell us a little bit about what you specifically did in the catheter lab and maybe how that might translate to other interventional specialties, surgical specialties, any particular obstacles? I know communication is very difficult in PPE and how you might have overcome those.
Yeah, that's a very good question, Resham. So as an interventionalist, we are used to wearing protective clothing and being in an aseptic state of play. We treated every patient that came to the cardiac catheter lab as being COVID positive. And by that, we had the first two operators, those standing closest to the patient, wearing full gown, full goggles, including protection on the side of the eyes, a full face mask, a FFP2 or FFP3 mask, over which sometimes we also put an additional surgical mask. And the reason we did that was because the FFP masks were in limited supply, and therefore, if we kept them covered, we could use them between cases. And of course, a hat. Every single case required very careful donning to ensure that we did not contaminate the equipment. And then at the end, very careful doffing, which required you to get changed without then making contact of the contaminated surface onto your own skin. As you've mentioned, when you're wearing such equipment, speaking very clearly is very important because our voice does not travel. And so staff can miscommunicate or not hear each other. In the cardiac catheter lab, we have microphones that helps a lot. If in some catheter labs that's not available, it led to very poor experiences. And so we moved very quickly at Imperial to install new equipment. This is very cheap, it is not expensive, does not require advanced equipment to deliver this. And in fact, we're having a mobile laptop computer with a webcam so that we could easily hear each other from inside the control room and outside. And this is something that surgeons can do and intensive care teams, as well as acute medical departments, as a way of increasing communication.
Thank you very much for Silk and very clearly explained. And thanks Resham to stand for me. And I was actually in technology challenge. Now I'm moving to Dr. Lutfur Rahman. Can you tell me briefly about safe environment in context of Bangladesh, or safe working environment for Bangladeshi doctors? I think probably you can tell us much better than anyone else.
Thank you, Dr. Mo.
Can you hear me, please?
I want to speak in
Yeah,
Bengali
please.
for the common people and doctors.
So, do you, Silk and Resham, do you mind if they speak in Bengali? I think probably the whole idea to like arranging this program to send a message across. I think probably because if he speaks in Bangla, I think probably okay.
Thank you, Manjur. Because we have heard a very good message from Dr. Shuk and Dr. Resham. Nice. They brief. I think those that understand English, the people has got the nice message from the UK doctors. Now I want to speak in Bengali for our common health worker nurses, other colleagues, and for other common people. যেটা আমি বলতে চাই, ডক্টর মঞ্জুর, তুমি বলেছো যে বাংলাদেশের ডাক্তার 70 জন উপরে ডাক্তার মারা গেছে, আমরা খুবই ব্যথিত। কিন্তু আমি আমাদের দেশে যে ডেথ রেটটা ডাক্তারদের, একটা বয়স্ক ডাক্তার যারা সিনিয়র,
and lots of old age doctor pass away, or the more of younger generation.
So right, like in battlefield, the general should behind, they should make the policy, and the soldiers they should fight. For this COVID crisis, the junior doctors should be in the field, and the senior doctors, they should guide, they should make the protocol to how to force the junior doctors, how to tackle the patient. It is the general care. The COVID treatment, commonly, it does not require so much treatment. So in ICU,
okay,
they need some critical support. So আমাদের যেটা বলতে চাই যে আমাদের যে সমস্ত সিনিয়র ডক্টরস আমরা এফেক্টেড হয়েছি এবং আমরা লস করেছি, এগুলা কেউ কোভিড ইউনিটে কাজ করতো না, কিন্তু তারা কন্টামিনেশন হয়েছে, তারা রোগী দেখতে গিয়ে।
Okay, what I could got from Dr. Luthu Rahman discussion, I think probably there was not a clear cut like guidance for doctors who will be working in the front line, and there was not enough risk assessment. Now I'm going to Dr. Hasina Nazreen, and you are infectious disease specialist, and you are the first infectious disease in Bangladesh. And like, if you feel free to, if you want to speak in English, that would be very much appreciated. And how did you find when COVID-19 crisis started in Bangladesh or around the world, especially for Bangladesh, and like how, as infectious disease specialist, how much you are involved to tackle this COVID-19 coronavirus?
And thank you, Dr. Shawkot, to invite me such a wonderful session. COVID-19 is an infectious disease, and it is a contagious, highly contagious disease. So infectious disease specialist should the leading physician in the management of infectious disease like COVID-19 and others. But unfortunately, Bangladesh has not enough number of infectious disease specialists.
How many infectious disease specialists in Bangladesh? 170 million people. How many infectious disease specialists in Bangladesh?
We are only 8 in number.
Only 8 infectious disease specialists in Bangladesh, and people contribute 170 million people. And I'll not be surprised if COVID-19 coronavirus takes a few millions Bangladeshis' life. I'll not be surprised, because only 8 infectious disease specialists in Bangladesh. Carry on, Nasreen. Sorry for the interruption.
No, that's not right. And as an infectious disease specialist, we are trying our best, and my other colleagues, other 7 colleagues also working in the infectious disease hospital. There is only one infectious disease and tropical medicine institute in Bangladesh, that is in Chittagong, and my medical university is also in same campus, and it is my affiliated institute, and I am also working there. And we 8 doctors are trying to our best, but 17 crores people with 8 doctors, how it is possible?
17 crores million, 170 million people. There's only 8 infectious disease. Are they all still fit working?
Expert, they should make the guideline.
Yeah.
And how much? I'm just asking. Sorry for the interruption. How much? Don't think I'm Piers Morgan. I'm not interrupting anyone. So how much you are involved preparing all these kind of like COVID preparation as infected? Did you much involved?
Yes.
Or you?
In the beginning of the COVID-19, we arranged scientific session and seminars on COVID-19, its prevention, about its prevention and control, how to pruning and doffing of the PPE, personal protective equipment, and how to take
Use
prevention
those.
for that. Yes, for prevention and for management, and also what should be arranged in a infectious disease hospital for management of the COVID-19, like a portable X-ray, separate isolation ward, what is quarantine, what is isolation. These terms are, this is
So
new
this
for
something bit
people.
of like medical school,
Yeah,
kind of
yeah. We
syllabus like a
arranged
medical school. You need to know.
Yeah, we arranged several seminars for COVID-19 prevention, control, management, and also, BITID, my affiliated by Chittagong Medical University. This is a Corona hospital, and we are working there. And me also treated several patients uh, through telemedicine, so my chamber and that hospital we're managing.
So you have
We
got
are trying
that.
our best.
My next question to you, because you are an infectious disease specialist, so COVID is an infectious
Yeah,
disease. Like according to World Health Organization guidelines, in a 250 bed hospital, at least there should have doctors who will lead the infection control for all the doctors and other healthcare professionals in the hospital. And
yeah.
how you have only 8 doctors? How to manage? Is WHO is one of the compliance for a 250 bed hospital? How many
Uh,
do you follow this kind of WHO guideline or?
yes. We are only 8 in numbers, so how can we fulfill that criteria? But at first, I
Thank you being
explain
very
you
honest.
how to
Thank you very
control.
being very honest. Thank you being very honest.
Yeah, yeah, but we are trying with our limited resources. So, and at first I am explain I am want to I want to explain you the process of how to control a pandemic. It is a teamwork. uh, Prevention and control, which is mainly aware to the peoples by the public health specialists, and trained by public health specialists, and also by infectious disease specialists. And epidemiologists should take a part, and also by virologist, by microbiologist, and cardiologist, respiratory medicine specialist, gynecologist.
Then
They
also
should take
intensive
part
care
when.
specialists, they also take
Yes.
although they are
Yes, yes,
experiencing
intensive
horrible
care
around the world.
specialist. Yes, also, they should involve. And in when in patient in ventilator and in ICU, then acute medicine and anesthesiologist also involved. And that is why in Bangladesh, many anesthesiologists are dying for COVID-19.
Yeah, so thank you very much for
Doctor,
sharing your experience from Bangladesh. Now, I'm going to
yes,
Resham.
doctor, yeah,
Resham,
I,
you love
I
the
want to
country.
participate.
You
Yeah.
had the experience from the infectious disease specialist. Do you want to say anything about that, or anything if with that limited resources, if they change practice? Like, well, we can't make it infectious disease, especially in a day or in a month.
So I think what Dr. Nasreen says is absolutely spot on, and it's a global problem. Um, but what you say about the anaesthetic colleagues being at particular risk has to be recognised, because they are involved in that aerosol generating procedure of intubating those very sick COVID patients, and they're very close. So for those colleagues, it's really important that we prioritise them, that we make sure that they have adequate personal protection, and that we share that risk, because it is a team endeavor, as you quite rightly say, and we must risk stratify those at the greatest risk and ensure that they are exposed the least. And it's really worth thinking through every bit of that protocol. So who's going to do the intubation? Where are they going to do it? Have they got the adequate protection? And making sure that we protect our workforce first, because without the workforce, we cannot help our patients. So I think that these are problems that are global problems, and that Bangladesh is very lucky to have you to lead this response. But the problems, as I say, they're global. We all suffer from them, but we must protect the healthcare workers.
And thank you very much for your wonderful suggestions. I'm now going to Suk. Like, Suk has a special interest in coronary microvascular disease. That's what cardiology knows around the world. He has got also another special interest with technology and cardiology. So, Suk, how the technology can help protecting doctors or other healthcare professionals in this COVID era?
Thank you, Monjo, for that question. I think technology is available to us for a very long period of time, but has been slowly adopted in healthcare systems around the world, principally due to old-fashioned rules or red tape and restrictions. Here in the United Kingdom, what we found was at the beginning of this pandemic, a lot of those rules and restrictions were lifted, and we moved quickly to restrict face-to-face consultations with patients and move to both telephone and video consultations. And this, in the modern era, is not as difficult as people imagine. Almost every patient has a smart mobile phone, which has very good cameras and enable you to see the patient and talk to them and explain their healthcare problems without being very close to them. This will protect physicians and healthcare workers and reduce their viral exposure. And I think that's something that all healthcare systems can readily move to constrain their risk of exposure. Also, technology allows us, for when we're isolating patients on COVID wards and we are preventing relatives from coming into the hospital, it allows the patient to keep close to their loved ones. And this has been a very difficult time. In many cases, patients have passed away without their family members by their sides because of the restrictions that have been in place. And simply using tablets and other smart devices with cameras, it enables patients and family members to be that little bit closer than they otherwise could have been without the use of those technologies. These are two very simple ways that are readily available to every single one of us and can easily be enabled and acted on without much constraint. Going forward, I imagine that healthcare will look very differently. I think we should all move to share our information and practical data. There has long been delays in publishing research and publishing data and protocols. That has very rapidly changed in COVID-19. I think we should share the information between the United Kingdom and Bangladesh, such that if you have a limited number of infectious disease doctors, then the pathways and protocols we have developed here can easily be developed and enacted in your local hospitals without the need of people to actually physically have to rewrite these protocols. And it's not an effective use of your time or effort. So I think technology will help share this information much more rapidly than was hitherto possible.
Thank you very much, Suk, for very clearly explaining how technology can take part. At the same time, the kind offer you have offered to these Bangladeshi doctors. Through this program, I would pass it to, already two doctors there on the show today. And I would also channel with Bangladeshi policymakers. I'll channel up with the medias. I would request them to invite both of you actually how the British health can help Bangladeshi doctors and patients. Now, we're going for a short commercial break for a couple of minutes. We'll be back after this short commercial break. Thank you.
চকোবাইটস শেয়ার না করে খাওয়া যায় না।
ক্রাঞ্চি বিস্কিটে চকো চিপস ভরা চকো বাইটস শেয়ার না করে খাওয়া অসম্ভব।
কালকে
ওকে কাল দেখা হচ্ছে কিন্তু।
রয়্যাল টাইগার নতুন স্মার্ট বোতলে সেই অরিজিনাল টেস্ট আর আনলিমিটেড এনার্জি। রয়্যাল টাইগার।
A very good evening from Channel 19. Today, our Health Plus show is a special program on doctor safety and COVID-19 coronavirus. I'm introducing our panel member, Dr. Silk Nia. He's one of the consultant cardiologists in Chelsea Westminster Hospital. And she has already advised and suggested a few things how we can protect Bangladeshi doctors, and also offered his kind help to collaborate with the Bangladeshi doctors and some protocols, which we'll discuss in further details with the policymakers in Bangladesh. We had got a Resham when, because of technology problem, when I was disconnected from this show, Resham, she stood up for me, and you did a fantastic job. Resham is a consultant cardiologist at Chelsea Westminster Hospital and is heart failure lead at the hospital. And we have got first infectious disease consultant in Bangladesh, Dr. Hasina Nasreen. We have learned few challenges, how she works in Bangladesh and how the doctors can be less protected in Bangladesh. And we have got a legend cardiac surgeon, Dr. Lutfur Rahman, and he is actually what he's trying to say. All of us are talking in English, but doctors in Bangladesh, he failed to say something in Bangla. Thank you, Dr. Lutfur Rahman. Stand up for Bangladeshi doctors, telling something in Bangla. And now we go to Dr. Lutfur Rahman first. What I would request Lutfur to speak in Bangla rather than English, because we have got lots of Bangladeshi viewers and you have got so many followers. I think probably one from there, and share your message from this show to the policymakers that might even save one doctor's or other healthcare's life. That would be our success. Dr. Rahman. So, Dr. Rahman, now my question to you, what kind of you advices you give to the junior doctors in Bangladesh? আপনি কি ধরনের অ্যাডভাইসগুলো আপনাদের বাংলাদেশি যে জুনিয়র আপনার ফেলো কলিগ যারা আছে to protect yourself in COVID era, কিভাবে how to protect yourself and colleagues in COVID patients?
রাইট, থ্যাংক ইউ ডক্টর মঞ্জুর। আমরা খেয়াল করেছি যে আমাদের অনেক সিনিয়র ডাক্তার লস হচ্ছে। এই সিনিয়র ডক্টররা নিজেদের আউট পেশেন্ট চেম্বারে তারা রুগী দেখে। তো এই আউট পেশেন্টের যেটা সেফটি মার্জিন, সেটা হচ্ছে রুগীকে ওভার টেলিফোনে হিস্ট্রি নিতে হবে যে রুগীটার মিনিমাম ইনভলভমেন্ট অফ কোভিড ইনফেকশনের চান্স আছে কিনা। তাহলে সেটাকে স্ক্রিনিং করে পিসিআর করে এইচআর সিটি স্ক্যান করে চেম্বারের ভিতরে আনতে হবে। জুনিয়র ডাক্তার নার্সরা এই পার্টটায় ইনভলভ হতে পারে, ডাইরেক্ট সরাসরি সিনিয়র ডক্টরের কাছে তারা যাবে না রোগীরা। তারা একটা ইনিশিয়াল একটা হিস্ট্রি টেকিং রুম থাকবে, জুনিয়র ডাক্তার যদি মনে করে যে এটা ডাউটফুল কেস, স্ক্রিনিং করে তারা সিনিয়র কনসার্নের কাছে তারা দেখাবে। এই একটা প্রোটেকশনের
Thank you, Lutfur Rahman. Can I ask you for a minute, please? I'm just sharing what you are trying to say. What Lutfur was suggesting, and actually something Suk has suggested, like screening is so important. In Bangladesh, lots of senior doctors are getting infected with COVID-19 coronavirus because there was not proper screening. And sadly, lots of senior doctors we have lost in Bangladesh, and especially in doctors with anesthetic and critical care medicine specialists, we've lost, and their old age. You know, the old age is a big risk factor, but 60 is a high risk group. But lots of senior doctors, what Dr. Lutfur Rahman is trying to tell viewers or the doctors, if you do the proper screening, that's what you have suggested that. Before actually, if you can use your technology, video phone, you can do the proper consultation and isolate the high risk patient from the doctors and other healthcare professionals. Can we move to the Dr. Rahman again, please? Can we move to Dr. Rahman?
Yes, that outpatient and inpatient procedure, like we are doing all emergency cardiac procedures. Before patient admission, we take details history of the patient and we'll ask for HRCT scan and RT-PCR test. When they are negative, only we admit them for the surgery. So if in emergency event, we wait 1 day or 2 days to screen out COVID, and we'll so all cases, all procedure we are doing after confirming by HRCT scan and RT-PCR for COVID. Then we are getting very good result. So our staff, all doctors, nurses are very safe. But even in ICU, we all deal all cases like a COVID unit. So we are very careful, all doctors, nurse, and mainly my all junior doctors, they are working inside the ICU and other things. I always, from remote control, I always consultancy. What is the problem? They come to my outpatient room and I give consultancy, this problem, but I very rarely goes very close to the patient. So senior doctors should be away from the patients and their relatives. They should only in contact with the junior doctors.
Okay, that's a good way of that. Can I share your suggestion to Resham and Silk? So what he has actually suggested and practicing hospital, he's working. So what they have said is that the senior doctors, somebody 50 plus or 60 plus, is still practicing medicine, and instead of like directly seeing them, what they have, if somebody is suspect of infection with COVID, they normally arrange that ask junior doctors to go to that, arrange the X-ray or possible CT scan to find out is any. Sometimes you can't do the PCR test; it's not very available like here. So, like looking at any changes in the lungs or CT scan, if CT scan or X-ray is normal, and then the seniors actually advise the junior doctors. And when necessary, senior doctors need to see a patient, only then they go in contact with the patient. That's actually a wonderful suggestion, because if you are a male, if you are 60 plus, and if you are a Bangladeshi, they actually fit all these criteria for
Exactly.
getting the high risk group. So now I'm coming to
Showkot,
Resham.
exactly. I do not go to
Oh,
cabin
okay.
round. I do not get to ward round. I do not. Usually, I try to keep away from the patient's direct contact. So all my junior doctors go to bedside, cabin, and ICU, and they feedback me and
Okay.
give suggestions.
So I got your message. What Dr. Lutfur Rahman is telling, that he doesn't go to like ward round or like in cabin, that in Bangladesh, or I think many parts of the world, like in developing countries, people rather prefer to go in those who can afford going into cabin, which we call side room here. Okay. Normally we put patient in side room, those who are high risk of infection. But in Bangladesh, people, those who can afford this, is more facilities than in a cabin or side room. So normally he doesn't go to like see the patient in ward round, and just to not get infected with COVID-19 coronavirus. He's asked junior doctors. Obviously they can listen patient chest, patient lung, and examine patient. So my question to you, Resham, what are your advices, like seeing patient in the ward? You tell something for the junior doctors.
So I think that that's a really sensible, pragmatic approach. I think that we are one team, we are one family, and we must look out for one another. And as you say quite rightly, the older people are, male gender, are all risk factors, and particularly we know that in the BAME community, in the Bangladeshi community, there is a high risk. So it's really important that we protect those people commensurate with their individual risk. And I think that what you're suggesting is absolutely the right thing to be doing, and could be adopted, could have widespread adoption. So in the UK, medical students were fast tracked through and have been helping out a lot on the wards. And I think that that's a potential pragmatic solution that can be applied in Bangladesh as well. So I think that that's really useful, but I think that it's also very important that you remember that many people are asymptomatic spreaders, and they can be asymptomatic for 2 weeks. So if those juniors are coming into contact with patients with COVID, that it's really important that we are protecting them with PPE, even though the risk to them may be much lower than to their seniors. There may well also, and I take advice from our learned colleague, but there may also be a dose response. So the more exposure you have to the virus, the more severe an infection you may yourself be prone to. So it's really important that we protect those juniors as well, and that we have pathways that Suk has outlined, where we are using technologies and we are using all the solutions available to us, whereby we're minimizing all patient contact to the bare necessary, so that we are delivering high quality, high volume care, but we're protecting our patient population as well as our healthcare workers.
That's a fantastic suggestion. I think probably like in Bangladesh, doctors are so panicked because of like how they can protect. Even yesterday, like I heard news that uh, even in March, doctors are not trained enough to how to wear PPE, how to use PPE. This is, and on the top of that, like getting in touch with a patient who is infected with COVID. This is a huge challenge for them, huge challenge for them. One thing I have noticed, my friends who are still working in Bangladesh, every day I speak to them, say, please pray for me. I don't know when I'm going to get infected with COVID-19 coronavirus. Well, as a doctor, we all try to pray, and all doctors are taught, not only in Bangladesh, everywhere. But I feel that they are feeling very insecure. One, that's COVID-19 coronavirus. I think somewhere around there is some clear-cut loss of managing or putting all the policies together. That's what whenever I speak to colleagues in Bangladesh, but I'm not personally blaming anyone, but this is something, this program is not to blame someone. This program is to helping policymakers, helping Bangladeshi doctors. Nasrin, I'm going to you, like you are an infectious disease consultant. Like if you advise one piece of advice today through this show, and if government in Bangladesh change practice from tomorrow, that could protect a doctor's life or a healthcare professional's life. One piece of advice.
In the beginning, health workers were infected as there was not much personal protective equipment. Also, the quality that they had was not good. But that problem is over. Now, health workers are infected because of the lacking of training for buffing and donning the PPE. Doctors who have died so far 25% are more than 60 years and with comorbidity. So I requesting all senior doctors to go to the direct contact to the patients. Please uh, give telemedicine treatment or uh, maintain proper distancing from the patient and not touch the patient. Non-touching method is, I think, it is so good for senior and junior all doctors in COVID conditions. And I may say to the patient, they should give the real history to the doctors, not hiding
This is
anything,
this is something. So good,
especially.
good. This is something. I'm not undermining anyone. This is I've got huge respect for Bangladeshi people. I love country. I'm still living so far away from Bangladesh, but my heart always
And
cry
this
for
is
Bangladesh. And this is
this is
something Nasser mentioned. Lots of time, doctors in Bangladesh came across patients and they say they have got temperature, but they have taken paracetamol tablet to get
yes,
better
yes.
because if there is raised temperature, the doctor will possibly not because they will think that because at the beginning of the problem there was no shortage of PPE. It's not only Bangladesh; it's around the world. So actual patients are not telling the truth to the doctors, and doctors
Yes.
do not know and they don't know how
Telling,
actually they get
telling,
infected. Yeah. So I share that thing too, and I will take both of your opinion about that. How could they overcome this problem? Carry on, Nasreen.
yes, they should maintain proper distancing from patients, and they can give telemedicine, and nurse should come to frontline fighter, and seniors are guiding them from back. Uh,
Okay. So,
no
so I think
coughing and
what
Doc, Dr.
so I
Munjur,
think I think probably
my
social distancing. Okay. Carry
yeah,
on, Dr.
Dr.
Rahman.
Munjur, I think in our country the number of tests is very less. So we doctors should consider each and every patient as a COVID case. Our precaution, our distancing like this, our attitude because no testing system, very less number testing we are doing. So our precaution is every patient and their relatives, we must treat them as a COVID positive patients. So accordingly, we should work in hospital and everywhere.
Yes, this is the rules in pandemic. When a suspected and probable case come, it should be taken as a confirmed case. This is the principle of pandemic.
Actually, Nasin, you mentioned something very important thing. If you suspect, because there are lack of resources or limitation of resources, because doesn't have enough testing capacity, and think about that might be a confirmed COVID case until proven otherwise. So we have got some
Yes,
good
yes.
suggestions from you, Resham. I'm talking Resham and Sue. She mentioned few important things. You have heard her discussion. What do you think does patients' kind of behavior like, to protect doctors? If they hide any information or if they don't tell the truth, I'm not saying any individual, but it is a brutal truth. Doctors have experienced this problem. What is your
So,
message to them?
Bonjour, this is a problem that exists everywhere. My wife is a doctor, a general practitioner, who has reported that many patients decline to admit to a fever or may have taken paracetamol, as you mentioned, and then they are found to have fever later and have had fever for several days, which they have not admitted to. But I think the comments from Dr. Rahman is absolutely the right way forward, which is to treat every patient as COVID positive until proven otherwise. And that is the approach we have taken here in our hospitals. And this requires a considerable change in your mindset as a physician. And you have to alter the way you practice. If we are truly honest with ourselves, we realize that although we touch patients a lot and we spend a lot of time getting very close, the true added value of that to the diagnosis is often slim. And the added value for ongoing management of patients by auscultating every air zone or lung field adds, again, very little. And once patients are admitted with COVID-19, then the treatment can clearly be protocolized and care can be administered without getting very close to the patient. We did this in our hospital by maintaining a 2-meter distance whilst wearing full PPE and only examining patients if there'd been a clear clinical change in their status. And this reduced the chance of the doctors getting infected. In some places, I also work at the Hammersmith Hospital, we were able to do remote ward rounds with the doctors who were most vulnerable of picking up the virus, those with health concerns, staying in another room completely and reviewing the patient through webcam, whilst the junior doctors reviewed the patients on the ward, but still maintaining a 2-meter distance. This led to no poor clinical outcomes, whilst maintaining safety for the patients and the staff. So I think this requires a cultural change as physicians. We are so used to sitting next to the patient when talking to them, but actually we can do the same at 2 meters distance.
Thank you very much. I think from your suggestion, what came up to the same thing, like remote ward round. That's what also Dr. Rahman mentioned about that. And I think people is actually learning from challenges, and people try to change their practice, and every single patient to treat as COVID-19 patient until proven otherwise. Now I'm going to Resham. Resham, you are also leading the echocardiography service at Chelsea Westminster Hospital. Like, how safe performing echo on a patient in COVID time?
So that's a very difficult question, Monjo, and obviously it's a risk not only to the healthcare worker that's doing this echo scan, but it's also a risk to the patient themselves. So for those people who are not familiar, an echo scan is an ultrasound procedure of the heart, and it takes usually about 30 minutes. in very close contact with the patient. So whilst not technically aerosol generating, it would only take one cough from the patient and there you have an infected healthcare worker. So this is like everything we're doing in medicine at the moment. We have to balance the risks and we have to have clear communication and we need to be very strategic about what we're doing. So I don't know what the situation is in Bangladesh, but I know that Suk mentioned in the UK, we're not allowing visitors or relatives into UK hospitals. It's the patient alone because we just want to minimize the number of people. In terms of echo, if we take it as an example of the tests that we have to offer, we have to think twice before we do this. We must think to ourselves, does this patient really need this echo? Are we putting the patient at risk by bringing them to the hospital to have the echo? And how is the echo going to change what we eventually do for this patient? And we really must question before we do things. So if we decide that this echo really has to be done, then we need to screen these patients. We need to ask them, have you had a fever? And it's really important in the communication that patients understand that by not being honest, they're not only putting everybody else at risk, they're putting themselves at risk. So we need to be very transparent with our patients. We need to be very clear in our messaging. We need to find out whether they have been in contact with anyone, whether they've had these symptoms, whether they are particularly vulnerable. Do they want to come and have this test? And how are they going to get to the hospital? How are they going to get to the facility? Who's going to bring them? We need to think about how are they going to come into our hospital or our healthcare providing facility? Are we using different entrances and exits? Can we do that? Can we plot how people move through our spaces safely? And can we provide every person that comes into our hospital with a mask so that they are protecting everybody around them? Can we take the temperature of people as they come into the hospital? Because the thermometer won't lie, even if the patient is going to lie. We need to make sure that we're screening them adequately. We're making sure the test needs to be done. And then it comes back to the same thing we've been saying over and over again, personal protective equipment. It's making sure we have as much and that our healthcare worker feels safe to do the procedure, that we're in appropriately cleaned facilities that are cleaned in between every single patient, that are well ventilated, and that we minimize the time. So I'm not interested in very long academic studies at the moment. There is a global pandemic. So what I want to know is the answer to the question I'm asking so that we minimize the amount of time people are spending in close contact. Do it where it's absolutely necessary, where it's going to change management, and let's minimize the risk throughout. But I think that all of this comes down to clear messaging from policymakers. Monjo, you've raised this time and time again. The countries that seem to have the best response have had a response where the messaging to the populace has been very, very clear, and that they have understood what they need to do. They've understood the symptoms, they've understood what their response needs to be, and that they've had clear pathways. And so I think that, you know, these are messages that can be applied to any healthcare setting. This is not resource dependent.
You are absolutely right. I think you have actually sent lots of messages across. There are a lot of things policymakers need to do for any healthcare setting. It's not in Britain and not in Bangladesh. And also something you mentioned about that, like if the procedure is not really necessary, you shouldn't do that. It's not the time for doing research on echoing patient and try to find some publishing paper. It's not the time. It's, and also maintaining a distance as much as possible. Now I'm going to Dr. Rahman, and like Rachel mentioned something about policymakers. We know that in the United Kingdom, Royal College of Physicians, Royal College of Surgeons, Royal College of Obstetricians, they have taken a huge role in actually advising government, British government and policymakers to take the best practice. How much you think that Bangladesh College of Physicians kind of like a prototype of like Royal College of Physicians, like or Royal College of Surgeons? How much Royal College of Bangladesh College of Physicians is involved guiding government of Bangladesh or policymakers? Because all these ministers or permanent secretary, they are not doctors and they are management consultant or politician. But how much does Bangladesh College of Physicians and Surgeons take an initiative to formulate this policy? How much they have done policy for protect doctors in Bangladesh?
Yeah. Dr. Monjur, which my belief, Bangladesh College of Physicians cannot change all hospital policy. Every hospital should follow another good quality hospital. Every surgeon, like we follow another surgeon, like good quality surgeon from UK or Singapore or India, like this. We must follow a protocol, otherwise I cannot do any surgery. My everything run by protocol. So hospital should have protocol. Hospital should follow another hospital protocol, and a department should follow another department protocol. So it is the clinical service depends on whom you are following. A hospital should follow another hospital like this. I believe that if our hospital administration follow a standard hospital either in Europe or USA, then we can change ourselves. Like I follow the protocol of many European surgeons,
No, no,
Singaporean
Dr.
surgeons,
Rahman,
Delhi surgeons.
can I stop you here, please? My apology for stopping you. Like you said, like follow the hospitals, and you have actually raised some important things: administration problem or management problem. So you mentioned kind of follow the hospitals in Britain or United States. That's why
Right.
the more reliable healthcare or credible health system. Whenever this is some kind of things I experience it, whenever I tried, I have taken so many initiatives, try to offer things that you can, if you take this British model, patient experience will be better. If you take this model, doctor will be trained much better. But whenever it comes to this, after the discussion, one of the experiences I experienced, it's oh, this is British model. We have got limited resources. We cannot do that, follow that model. And you are
Not
saying
true.
that
Right.
if we can take the best practices from the developed countries. So how, like I know what kind of feelings you have got for shaping the Bangladeshi health system or making patients' experience better. But this is challenge I came across. Oh, this is for Britain. We are not that far. Oh, no, it will not work in this country. Uh, I don't know why this kind of like kind of philosophy is coming from. So this is British standard. It will not in our country. Do you have any comments about that? I'm not saying I'm not too personal to you. I'm saying as a whole. Like you don't need to write a heart-failure guideline. Like they all have got a similar kind of clinical features or things. Whenever I try to push them, can you copy that British guideline? Can you practice that? You don't need to write another protocol how you treat patient, and But whenever it comes, like technologies, there you even don't need to send it by post or DHL. It's simply one email you can kind of guideline. But I have noticed this in Bangladesh. There is a reluctant to take these kind of things. Well, this is not a personal question to you. I know you are a very good friend of mine. What is your view about that?
Dr. Munjur, yes, perfectly the question is raised. We, during this COVID last 3-4 months, we observed everybody is expert. Everybody is expert in Bangladesh. Morning one decision, evening it is changed like this. So nobody is following any standard protocol of any standard country or any standard hospital. So my request to government and all health staff, you must copy and paste. Don't do research in this time. You should copy and paste of a developed country, developed hospital, developed surgeon, developed
How they are
person.
doing?
Copy and paste is the best way of success in life.
It's a wonderful,
Copy and
wonderful, wonderful comment from you. That's why I really, I really appreciate you. I always try to meet you and see you, and like what you just simply suggested, copy and paste. You don't have time in copy there. You don't have time to do your draft, your planning. You need to this. Public Health of England, they have got clear-cut guidance on how to wear PPE. Even you don't have to pay anything. You just to go into Google. What's the Public Health England guidelines for wearing PPE? How to use PPE, drowning, doping, all these things you can. You do not have to pay anything for this. I don't know. This is the things I raised here. This is nothing personal to you. I have experienced lots of I've tried. I requested, and whenever it come like not only heart failure management, any kind of things. Oh no, this is not will not be suitable
Dr.
for our
Dr. Dr.
country.
Dr. Shawkot, let me say
Yeah,
about training of PP. CDC Dizzy Health is now starting training about how to donning and doffing of PP, and all medical college this training is occurring to health workers. At the beginning, some problems, but now um, I wish it will be solved because training is occurring under CDC Dizzy Health.
Which is
okay,
wonderful. But if there are, Monjo, if there are people that don't have access to training, you can find it
yeah,
on YouTube. So there are
Right.
videos
yes.
that you can watch on YouTube, and anybody can watch those, whether you're a porter or a janitor or you're an anesthetist. So there are videos online, but can I urge people, it is not a false economy. I know that PPE is hard to come by, but it is really worth practicing. And it's really worth practicing with someone watching. And the key point about the PPE is not putting it on. Um, Putting it on is fine. It's taking it off. So that's the bit to practice. And it's not a waste if it saves your life. So watch the videos. You cannot watch them too much, but also practice yourself. Get a friend or trusted colleague to watch you and make sure you practice taking it off safely.
Thank you very much, Rasham. I think lots of doctors here in the Britain, when the COVID crisis started, YouTube channels are very popular. Other day, I was discussing with my colleagues. Many of them actually shared, and lots of them watch YouTube video. I don't know what was your experience or success experience. And actually, the technology is so friendly and so helpful during this COVID era. Actually, technology is helping us so much in COVID era. Otherwise, what Suk suggested, that a video consultation, if there is not kind of a very good video camera, we cannot see patient, or we cannot. We are taking actually maximum from technology during COVID era. It's not only using for
Yes,
using social media
Dr.
or other
Monjur,
stuffs.
yes, Dr. Monjur, Doctor. This COVID time, I always keep my eyes on camera. What is going inside the theater? What is going in the ICU? Actually, I become the observer in the camera. Really, I control by everything by camera. And I call telephone. I do this, don't do this, like this. Camera, web camera is my main basic principle of treatment.
I think, Dr. Rahman, I think, well, this you are doing a fantastic job. Make sure you find a good friend who is especially as I especially need to find good friend, because if you put too much concentration in camera, you please do regular eye checkout. Otherwise, you'll see COVID has saved your patient, saved you with the cost of your eyes, because and I think well, doctor's life has transformed because of COVID, and I know the feelings coming from all four of you. This is something like the experience you gained throughout this critical time. You all came with a good intention to help doctors in Bangladesh. I must appreciate all of your wonderful comments, suggestions, and advices. Just before ending our show today, I'm giving everybody 1 minute time. Take home message from
Yeah.
this show.
Yeah. Dr. Munjur,
I start from,
my
yeah,
message,
go.
my message is the old one, survival of the fittest. Those are fit, they will survive. So remember this mind, you are a doctor, you are a people, anybody, but survival of the fittest, you must be enough awareness enough conception, so you will survive. So survival is the fittest is the everywhere applicable.
Thank you, Dr. Rahman. Now, Sue.
Thank you, Monjour. So I would summarize by saying, make sure that you are appropriately educated in the use of PPE. Make sure that you work with your teams to bring PPE into the hospital, but not just for yourself, but for all of your staff and all of your team. Protecting all of your team will protect you and your patients. And this is why we all became physicians and doctors, in order to protect patients as well as our team members. And if we look after them, they will look after us. And so that is absolutely key. And that's what I would recommend to all of the doctors in Bangladesh.
Thank you very much. Thank you. Now I'm going to Nazreen.
Thank you. We have to treat patients, but after protect us. So maintain distancing from the patient, non-touching method, telemedicine Sheba. We are living in digital Bangladesh, so telemedicine Sheba is very easy. And যখন আপনারা পেশেন্টকে দেখবেন তখন ট্রায়াল সিস্টেমটা আপনারা ফলো করবেন। ট্রায়াল সিস্টেমে স্ক্রিনিং করে তারপর পেশেন্ট দেখবেন। পেশেন্টদেরকে আমি বলবো প্লিজ আপনারা হিস্ট্রিটা হাইড করবেন না, সত্যিকার হিস্ট্রি ডাক্তারকে বলুন। ডাক্তার বাঁচান, ডাক্তার আপনি বাঁচবেন। ডাক্তার যদি না থাকে তখন আপনাদের চিকিৎসাটা কে দিবে? এই কোভিড কন্ডিশনে ডাক্তারদেরকে আপনাদের বাঁচাতে হবে। আর ডাক্তারদেরকে আমি বলবো আপনারা আপনাদেরকে প্রোটেক্ট করে তারপর পেশেন্টকে সেবা দিন। আর পিপিইর ব্যাপারে প্রত্যেক রোগীর ক্ষেত্রে কিন্তু পিপিই একই না। যেমন কোভিড পেশেন্টের ক্ষেত্রে একরকম পিপিই, নন কোভিডের সময় একরকম, অ্যারোসল প্রডিউসিং যে ভেন্টিলেটরে থাকবে তাদের জন্য পিপিই একরকম। এই জিনিসটা আপনারা খুব ভালোভাবে ফলো করে ডনিং ডফিং এবং স্পেস, এই যে ডনিং ডফিং পিপিইটা আপনারা যে খুলবেন এই স্পেসটাও কিন্তু আপনাদেরকে আলাদা করে সেভাবে ব্যবস্থা করতে হবে। ধন্যবাদ।
Thank you, Nazreen. Thank you for your wonderful comment. Now, Resham.
So it is our great privilege and pleasure to serve our patients, but in order to serve our patients well, we must work as a team, as a family, and we need to protect our most vulnerable within that team, as we've described today, and we need to protect all of us with the PPE, with the clear protocols and guidelines that we're going to.
I think probably we lost Resham. I should show my friendship to Resham. This time I need to stand up for Resham. I think she has already given so many advices and messages. And actually, in COVID era, I'm talking for Resham now. In COVID era, we need to work as a team. Doesn't matter you are a doctor, you are a nurse, or you are a healthcare professional, or a reporter. We are one team. We are healthcare professionals. We need to protect ourselves. We need to protect our patient. And thank you very much. And before starting up the show, my heart was beating a bit faster because I was not quite sure how it's gonna go. But in a minute, that will be end of our show. But I felt my pulse. It is absolutely normal. Thank you very much, Sue. Thank you, Resham. Thank you, Nazreen. And thank you, Dr. Lutfi Rahman. Thank you for joining us in this show. Thank you very much.